Welcome everybody back. This is Pod Patrol, and I'm Jeff Dykes. Joining me today is Dr. Michael Theodoulou out of Boston. Thank you for joining me today.
Thanks for having me, Jeff. I truly appreciate it.
Yeah, absolutely. I'm looking forward to this. I heard you on a recent podcast called Life of Flow, and you've been very involved in this particular, we'll kind of leave it hanging so people stay tuned to hear all about it later, but this particular procedure and how it's gaining traction here, we'll kind of dive into that later. But let's talk about you for a little bit. You went to Shoal College, and then how'd you end up out working at the Harvard system out in Boston?
Yeah, I finished my residency training down at Baptist Hospital in Memphis. Don't think the program actually exists anymore, but it was a great experience down there. And then my wife was from the Mid-Atlantic, so I went back to Washington, D.C. Practiced there. Was at Georgetown for a while, too, with Chris Attinger in the group and the orthopedic department, and also had my practice there. And then, things evolved where we moved the family up to the Northeast. We have family up this way, and an opportunity arose up at Cambridge, and I thought, hey, this would be a great opportunity to work with a nice residency program, get part of the Harvard affiliation, and kind of pursue some things besides the day-to-day grunt work that we do, and maybe advance a little more research and academics. And so it's been for me a great mix. So I've really had, and people have said this, I've had two professional careers, one in the world that I had in DC for a while, and now this other professional career, which has been great. So that's kind of my history and evolution of as being a podiatric surgeon.
Yeah, so let's talk about the residency for any younger people listening. So that's Cambridge Health Alliance. It's one of the programs there in Boston, affiliated with Harvard Medical School. And you guys take 2 per year, but you want to talk about the residency just for a minute?
Yeah, so the residency is everywhere, 3-year residency. It's a rear foot ankle program. And the residency, we have an interesting patient population. Cambridge Health Alliance is a public hospital system. It's operated out of the Cambridge city, second largest public hospital in the Boston area besides, I believe, Boston Medical Center. And our patient population is very unique. You would think in the Harvard community and world, you would not see public health that we see and the issues. We have a large immigrant population, Portuguese, Brazilian, Haitian Creole, Spanish, and we treat a challenging population. Many come in directly from their main resident countries, and we see processes that have been many times eradicated in our Western civilization and industrial care of medicine. But we see a lot of ongoing polio issues. So we see a lot of post-polio processes. So we see a significant pathology. Part of which is also what I'm involved with in limb salvage as well. So it's an excellent general 3-year program with trauma, reconstruction, limb salvage. I do a lot in orthoplastics. 2 of my chapters up I'm writing on now are as orthoplastics. And so the residents get an excellent exposure to all aspects of lower extremity care with us and my 2 partners that I have, for sure.
Yeah, so those are kind of on obviously the complicated end of the spectrum when you start talking about post-polio and diabetic limb salvage and reconstruction and all that stuff. So if you're looking for a program, orthoplastics obviously included in that. So if you're looking for a program that's got some of that higher end towards the complicated end of the spectrum, I think that's a really good program, really good experience that you may not find. Well, I know you won't find at a lot of different programs out there. So really interesting to be able to be exposed for the residents to get all that exposure and experience with you guys out there. So what made you go into podiatry? What kind of guided you toward that specifically?
I actually I was undergrad at a small Western Michigan school, Kalamazoo College, and was playing collegiate soccer, and actually had a Lisfranc injury. At that time, not well recognized and treated because that's the mid-'80s, so to speak. And actually was turned on to by the therapy department there, a local podiatrist. I was already accepted to medical school actually, and was going to go, and I wanted to be upper extremity hand surgeon. My dad was an orthopedic surgeon, and had this foot injury that kind of turned my world around, so to speak. Yeah. And they said, and I said to myself, wow, I have great interest in in extremities, distal lower extremities, seem great. And the care that I received and the work that I saw even at that time kind of excited me about this opportunity. And so kind of jumped in and started to apply afterwards to pediatric medical schools, got accepted. And Scholl being a Midwestern school, and I was principally raised my secondary school education. I was born in Montreal, but raised principally outside of Detroit. It was a great opportunity to do Midwestern school, and so a continuation off from Kalamazoo to Chicago, and so it worked out pretty well.
Mm-hmm. Do you run up against any issues in terms of the scope of practice in Massachusetts? What's the latest on that? And
yeah, Massachusetts is a challenge. By definition, by scope, we're very limited. We can't even really theoretically amputate, and the definition of foot remains extremely gray. The board definition, and these are issues that other states have dealt with in the past, has had a different definition of podiatry and what it can do to include foot and ankle and in our surrounding states. I'm very blessed in being in an academic teaching institution where I have the support of my allopathic colleagues, osteopathic colleagues as well, to do advanced scope type of work that I do. I don't feel limited. As you'll see here, I do proximal tibial work. I put on frames everywhere. We do trauma about the foot and ankle. So even though scope is challenged in Mass in some regards, in academic centers and where we function, it seems to work. We seem to be fine with it. So, but it's still an issue that needs to be resolved. There's no question about it. There's this conflict. It's antiquated. But Massachusetts and Boston politics, as you may appreciate, is an extremely challenging political system. And having been past president of the Mass Foot and Ankle Society and being knee deep into that, I experienced it firsthand in the battles. It will change, and I think how it will change is this ever-growing preservation of our youth staying in the community, those that we train, those that have advanced scope of training and practice, continuing to break down walls that have existed and demonstrating their skill set. And I think as that unfolds, we're seeing things emerge more and more, but it'll be that type of process that I think will ultimately resolve the scope issues that we've been dealing with in Massachusetts, for sure.
Yeah, I think it's tough. I think some of that just takes time.
Yeah.
Some things happen quicker than others, but yeah, I think I've always said that if we can kind of demonstrate, we're not just asking for something, let's go out and show that we're as highly skilled as you can possibly be, and then they won't have any argument against it. So
we can all profess our expertise. It's really demonstrating what we do and how we do it and our outcomes and how we communicate and educate not only our public and but also our colleagues. And I think that's a critical aspect. So it's evolving. I think it will change for sure. I think as a profession, we serve the community and amazingly well. But like everywhere else, it doesn't matter what your scope of practice is. There are certain bastions out there of systems that are controlled by specialties that will limit no matter where you're practicing. And
right.
Those are the battles we all face.
Yeah, for sure. What are some of the favorite cases that you like to do? Obviously, if you've chosen to dive into orthoplastics and limb salvage, that kind of tells me the answer. But what specifically do you really find the most interesting about the profession?
Yeah, I mean, we can talk about, complex limb deformity correction. That's what kind of drove me into this realm that we're going to speak about a little bit, and its understanding and Elizaroff and all these processes. Mm-hmm. So deformity correction, neurologic induced deformities, cavo varus is a big one that we deal with. Bone defects, significant osteomyelitis cases, restorative type limb preservation cases. joint preserving or joint movement preserving cases, as we see. So those are the kinds of things that have kept me extremely stimulated from the standpoint of my personal practice and how I train and educate and the things that actually get referred in. As you know too, Jeff, and most of us know, some of these complex deformities, not everybody really wants to take on.
Mm-hmm.
They don't. They simply don't. And you become known as that person who will take it on.
Yeah.
There's risk always associated with the standpoint of outcomes. And part of this is, again, having great relations with your patients, education, looking at every case and uniquely. I also, there's times we all look back and say, just because I could, should I? There's always outcomes you wish you kind of could take back, or results or cases. To move the pendulum forward, and this is kind of a great, I'm not going to segue us yet, but to move the pendulum forward, there's always been individuals, and I'm not saying I'm that individual, but that have to take that leap of faith to try to see, is this a good direction to go? And obviously, no one does this rashly. No one does this with any intent to harm. Is there a basis for it? Is there rationale behind it? Can it help somebody? And we all go in with some of the stuff that we do with, guarded care and control approach.
Yeah, I can appreciate what you're talking about with being a tertiary referral center. We dealt with that when I was in Pittsburgh at the University of Pittsburgh and working with Dr. Burns and Dr. Wukic, and we would just get all these severely complicated, what? I've never seen that. This is crazy. And then you kind of think in the back of your mind, like, all right, I'm ready for anything. Then you get out in the real world and you're like, where is all that stuff? And even I do get it, I'm sending it to Pittsburgh.
Yeah, it's funny. I was just with Dane 2 weeks ago down in Dallas, because he's on my surgeon advisory board with what we're doing here, and obviously, but we were talking about this exact topic and the challenges and sometimes having it. And he was talking about it at UPMC liver transplant and having to put blankets outside the door because the amount of blood loss that was going on in those ORs. But these were the cutting edge, so to speak. This was how we had to advance ourselves to, or take these approaches to, move forward to advance care, especially in medicine and surgery and managing, complicated cases and situations. So, it was kind of funny. We had this very philosophical discussion a couple of weeks ago down in Dallas talking about some of this. Yeah, so, tertiary centers, we do tend to get this, like everybody else, nobody wants to treat Charcot. They can be very humbling surgeries, cases. And
even if you do it perfectly, it can still fall apart.
Yeah, exactly. And you get known to be able to want to do these. Ultimately, you also get hopefully known to have, in general, good outcomes and know how to treat the presentation. And, but, as my father always said, you can do the same surgery over and over again, but the canvas you're painting on changes every time. And that's it. So we're dealing with unique patients, unique individuals, unique circumstances. And so this is what makes medicine fun, also makes it challenging as well.
Yeah, absolutely. Keeps you on your toes. So let's jump ahead and let's start talking about what you've been passionate about recently, which is tibial cortex transverse transport.
Yeah.
So anybody not familiar with that, you want to kind of give a brief introduction into the theory behind that, where it developed and where we're at today?
Yeah, so the theory is not new. It's been well established. This is from the 50s with Elizaroff. And actually, I will take a brief moment to say I was flattered and honored that we were actually presenting this in a recent forum in Boston at Beth Israel and their diabetic limb salvage thing, talking about this no option reconstruction of these patients. And as I was sitting there and we were presenting, I got this nice email from Stuart Green. And those people who don't know Dr. Stuart Green, he's an orthopedic surgeon from the era of the 70s and 80s, and we had this great discussion because that's kind of the era of my father. But he was actually the gentleman who co-authored and brought a lot of the work of Elizaroff, and particularly tension stress effect, to the United States. He actually coined the term that many of us use now, rancho, and rancho cubes that we put on our X fixes, and that was an interesting story he kind of told me. But he actually brought in and brought into the United States some of the principles that Elizaroff was proposing, and that if you take bone and you put it under a continuous stress or strain, we see a regenerative effect take place. We know that. We see osteogenesis, we see neurogenesis, we see angiogenesis that takes place, and we see it focal to the area that we work. But we started to look at, does it remain focal? Is there a principle that, is it a confined process that we get, or do we get, so to speak, a humoral response? Not, so to speak, truly a humoral response, where we actually get a cytokine response that if you take bone and you put a gradual continuous strain on that bone, is it local, or do we get a general systemic response? And it was really our Chinese orthopedic colleagues in recent times that really looked at this. Initially, they looked at this purely at addressing peripheral arterial disease, but then they started looking at it from a diabetic foot standpoint and healing severe neuroischemic wounds, and so they did a fair amount of work, and outcomes were quite impressive, and I was alerted to it. So I had a history of deformity correction in dealing with the Elizaroff type work and ring fixtures and osteogenesis, and then started, it was kind of a perfect storm where then looking at my limb salvage world, and then this came to my attention. And specifically out of a presentation that came out recently at one of the AOFAS conferences, where they presented their outcomes on diabetic foot and limb salvage doing distraction angiogenesis as to healing properties. And so all this came together. So this is a well-recognized process, and we've begun to learn more and more that tension, stress, or strain isn't relocalized, but actually has a systemic response that we're actually kind of harnessing and employing to get some of these challenging wounds to heal.
So let's talk about osteogenesis just for a
Yeah.
second, because I have a wide range of listeners from students to whoever.
Yeah.
So let's talk about Elizaroff and osteogenesis, and what was the foundational reason for even considering osteogenesis in the first place with these ring fixators?
Well, the thought process was that is, again, it came down to, could you do in a controlled fashion an osteotomy of bone, and through controlled fashion create new regenerative bone into an area and create healing within that bone? And these principles a lot came from traumatic, from infected tibial long bone fractures and things. That could we restore bone defects utilizing a principle of this constant strain on bone? And that's really where it came from. And then those principles advanced to deformity correction and to where we kind of are now. So generating new bone through this constant strain, this modulus of bone that we know that we can get neovascularization. And through neovascularization, we can lay down our basically our calcium model, and then ossification that we take, our cartilaginous model, apologize, and then ossification of bone through that entire process. And then learning under the principles of how much you can strain that bone before you lose that effect. And so those were some of the initial battles that we've got. Some pretty standard appreciated models now in mechanics and on how fast we should distract bone and to what degree. And so that's where it really evolved from.
So perhaps bone infection, perhaps bone tumors, anytime where we're going to have a bony defect where we need to cut something else out, or a limb length discrepancy, some sort of congenital deformity, anytime that we need to take bone that isn't there and create new bone. And so, maybe brachymetatarsia or something like that, where we're distracting slowly and letting the bone form as you distract. but then we base that principle, we understand the principle of osteogenesis, but then what kind of has transformed is the idea of angiogenesis, the formation of new blood flow that comes from the original process of osteogenesis. So during the process of osteogenesis, in order to form new bone, we have to form blood vessels to supply the bone. And that's the foundation of this theory. Or it's not even a theory, it's how it works.
It's just basic principle. It's not even a theory. It's recognized. And when you think about it, if you look at standard healing of tissue, and you have an acute injury, what's the first thing that happens? We have bleeding that takes place. Well, what's the first cellular response? Platelets come into that area, control, get hemostasis. Well, what do those platelets have? Those platelets contain all the cytokines that we're looking for to then advance the next healing process, whether that's whatever growth factors we speak about. Specifically to this, we're looking at vascular endothelial growth factors and its response. Is that response then just unique to that area? And what's interesting in our current, and I won't dive into it much, but what's interesting in our current review of meta-analysis and looking at some of the review and doing some regression analysis of outcomes, it's interesting. It's a very systemic response. And in fact, some of the interesting side effects that we're seeing is that this can also have a cardioprotective effect. So a lot of these sick people that we're dealing with, we really are beginning to appreciate that not only are we getting a response to healing of what we're trying to heal, a tissue defect, and that's really what we're speaking about here. And we can kind of talk about that a little bit too, Jeff, in the sense of what we're trying to really address here. These are tissue defects, but not only are we getting that vascular endothelial growth factor response to promote increased blood flow into that area, but we're also beginning to see that there may be, again, a cardioprotective effect. We're seeing an incredible response to this approach throughout the entire body, and it's been documented. There's no question.
Yeah, I find it really interesting. So as I've come to learn about it and understand it, the way that it makes sense to me is that these people kind of get stuck. The cells are senescent, and this new controlled traumatic insult is almost waking it up. Whatever it may be, in this case, you're kind of like stirring up the pot and making things come alive, and the body's starting to say, oh, all right, let's wake up. Let's start doing something. It kind of starts the whole process going.
And it's interesting because, so why this? So I will, when I was on that other, we discussed briefly, I was on another podcast with some vascular colleagues. They suggested themselves, well, so one of the things that we, obviously the intent is to preserve a functional limb in these types of cases. There's no point going through all this process if ultimately I'm not restoring a limb that a patient can truly function on. So number one, when you're going to put somebody through this approach, that we are going to, I'm going to restore something that they can use and be functional with. If the presentation is such that that will never happen, then what's the point? But when you're considering this type of thing, we're looking at tissue defects. So a lot of times these are cases where I may do a guillotine transmetatarsal amputation on a patient. They've got a diffuse gangrenous forefoot. They don't have adequate perfusion to support that. We're going to go ahead and do a guillotine amputation, preserve as much of the length of the foot as we can so that they have a good lever arm to work with, and then employ something like this. The interesting thing is I really look at this as a regenerative, as you just pointed out, a regenerative approach to healing. We have to kind of function in parallel with our vascular colleagues. And our vascular colleagues are struggling and battling with these types of cases too, where you have no option, non-reconstructible, or they've already reconstructed. It's not. And now, of course, looking at deep vein arterialization and things like that. But what my vascular colleagues are doing is creating a patency of highway. They're creating a patency of highway of blood flow to a part. They can do a targeted patency of restoration to a part if they've gotten that good, and they've gotten so good to, get to forget angiosomes. Now we're talking about perforasomes. So they've gotten that good where they can do that. What we're seeing with our approach may be in augmentation to that is that we're actually creating a diffuse, non-targeted regenerative response because of this cytokine flare, is how I best describe it.
Mm-hmm.
And it's amazing. And we have images and pre and post performance, pre-catheter angiogram, post-catheter angiogram, where there's no dye diffusion down to the foot, and then post 8 weeks, you see this incredible network of dye into the foot robustly throughout the entire foot.
Yeah,
And
that's
that's what's impressive.
Yeah.
That's what's impressive.
Well, let's jump into it then. So hopefully everyone is able to visualize this as we kind of go along, because I think above all else, this is going to be very visual for people and understand a lot better once they can see what we're talking about here.
Yeah, so the original principle, and this was the concept of a tibial corticotomy, and this was done, again, most of this literature was done by our Chinese orthopedic colleagues looking at this, and they were looking at severe, and of course, whatever classification you want to look at for diabetic foot ulcers. I think it's important for us to recognize before we jump into this, Jeff, that when we look at wounds particularly in the diabetic foot, historically they're ischemic wounds, vascular-based wounds, neuropathic wounds because of pressure and neuropathy. But we do know over the last quarter century for sure that there has been a significant increase in neuroischemic wounds. So a combination. We're not only dealing with a neuropathic pressure-induced wound, but we're also dealing with ischemia of tissue. Now, why is that the case? Great question. I don't know if we know it. Maybe because of modern-day medicine, people are living longer. We can sustain their diabetes or whatever the underlying cause. But regardless, we're looking at neuroischemic wounds. So in this case, what they're doing is a tibial corticotomy. This is what originally came out. And what they realized with cortical distraction, that we can get growth factor expression, angiogenesis, we can reform distal collateral circulation, we can locally rebuild the microcirculation and increase O2 supply to the area. And of course, we have regenerative tissue that's occurring, osteogenesis, neurogenesis, myogenesis. But distally, we're getting this humeral response of angiogenesis distally to it. So the original approach was using a monorail windowed corticotomy. It's a unicortical corticotomy. It's not, and the translation is nothing more than basically opening the drawer to cabinet, so to speak.
Yeah, lifting the cortex off of the surrounding bone.
And interestingly, there's increasing look at just doing periosteal elevation and not doing the corticotomy. And so there is some recent looking at just doing a periosteal elevation and not doing the window corticotomy to see if we can get a similar response. I'll be honest, I don't have a lot of literature understanding on that, but that is being considered as well. These were the original approaches. We changed in my looking at this. I was concerned about the stability of this corticotomy, and we can talk about actually tomorrow. I have one of my cases that did develop a proximal tibial fracture, whether it was an insufficiency fracture or not. Patient did fall, a very sick individual, actually fell after sustaining cardiac arrest, myocardial infarction in recovery. He was resuscitated, survived, but upon falling, he had 2 defined falls, fractured through my proximal tibial osteotomy. I actually took him to the OR last week to stabilize it, put him back in a frame again, and now my ortho colleague is going to do an antibiotic antigrade nail for this proximal tib tomorrow. So that is a known risk, and because of that known risk, I was a little concerned about just utilizing a monorail on these patients, particularly my patient population. So we modified this to incorporate a ring fixator to have a multiplanar stabilization of this osteotomy with a created engine using the ranchos that you see there to create a distraction. Now, in honesty, we have developed and going through a process now of an engine that will simplify this. It can be readily attached to a ring fixator and perform this. And so we're in the midst of doing that, and we're excited about it. I think it will really simplify this process. But We incorporated a ring fixator for a couple reasons: multiplanar stability. Secondly, I felt it was easier if I'm offloading, so orthoplastics, as we speak about, offloading a distal wound, I can extend that ring fixator down distally, as you see here, and do an offloading foot ring and work on that. Some of the most challenging wounds, and the ones that we always hate having the consult for, is the heel wound that we deal with. That heel wound is a nightmare, and we all know the high risk of limb loss with these because of the comorbidities that drove that patient to have a heel wound to begin with. But if I can offload that heel wound as well, do the corticotomy, it made all the sense in the world. Basically, this is the approach that we take. And I will say initially when we did this, I kind of followed my orthopedic colleagues from China in approaching this. In fact, my original approach was more of a curvilinear approach over the soft tissue, not directly over the bone. We found that a little bit challenging because to go ahead and to complete the corticotomy and get around the soft tissue was a little bit more increased soft tissue violation and dissection. So we ended up initially doing a direct linear placement over the planned window corticotomy. I will say now we don't even do open incisions, and I've brought on an incredible advisory board, many of which Raquel Saguna and that really are involved in the MIS world, who looked at me when she came in to watch me do a case as she was preparing to start doing these. So, Mike, why don't you do these minimally invasive? And I said, yeah, I don't know. I do percutaneous stuff all the time. So I will say right now that these corticotomies are now being performed minimally invasive. Basically a 6-hole type technique, 4 in the radial cuts in the corners, 2 mid portion of the longitudinal arms of the window, and we can complete the window corticotomy without making an incision at all. So I do these percutaneously, but this is the incision approach that we took. Down to periosteum, preserve the periosteum, use the engine to kind of plan where we're going to do the corticotomy. It's in the medial face. I place it far enough distal in the metaphyseal, diaphyseal region so that when I put my ring fixator, I'm not going to potentially worry about landmarks such as the fibular neck and the common perineal nerve, so I'm far enough distal to protect those vital structures. Incision is made. And initially when we did it, we really went by the Elizarov technique of creating drill holes and completing with an osteotomy. We started changing that to facilitate this to utilizing a sagittal saw, as we still did open approach. But it was a very traditional corticotomy, minimal damage to bone and periosteum. And now, of course, we've taken it to percutaneous approach. But this is a good way to look at it. When my colleagues start first doing it, I think it's a reasonable thing to do. We actually started designing, as you can see there on the bottom, actually a corticotomy guide. I think it's still reasonable, especially for surgeons who want to do this as an open approach versus an MIS approach. And we're completing the osteotomy with an osteotome here. Again, we've evolved as we've done these. This kind of gives you a sense of what we're trying to achieve here. Again, a unicortical corticotomy, threaded half pins in place that will drive the translation of the bone.
This is my favorite slide. So to make sure that you put the ring on.
Oh, yeah, sorry. Yeah. So being the fool that I am, if you look on the bottom left here, you will see my ring wasn't proximal to my half pins. And then, so we've all done it. And the interesting thing, this will change with the engine we have, because we'll have the engine mounted on the proximal ring. You can actually use the ring as a steering wheel to secure yourself as you do this. Literally, I will tell you, we've got this down to about a 20 to 25 minute procedure now. So It's a very straightforward procedure.
Sure.
But yes, putting the proximal ring, otherwise you'll never get it over those half pins. Exactly right. Love that. And we've all done it.
Yeah.
And then the completion, as you see here. And then the final construct, putting thin wires, skinny wires to secure this standard X-fix approach that we do, knowing our safe zones, protecting our anatomy. And this is really kind of the final construct that we have. And then the protocol is pretty standard with all distraction osteogenesis. We do a latency period of about 5 to 7 days. And then we begin a lateral cortical distraction of 1 millimeter per day for 2 weeks. And that's a quarter turn per day. And then we do a restorative. Now, I will tell you, Jeff, I've kind of, as we all do, kind of want to mess around with the recipe every once in a while. And so I thought about doing the opening the drawer, closing the drawer, opening the drawer, closing the drawer, where I would do a weekly of distraction, relocation, distraction, relocation. I didn't see a difference in doing that. But my thought process behind that was that potentially this would create a more of a response. I really didn't see it. So what we're doing is truly distracting for 2 weeks, a millimeter a day. And you can tell that's about a 1.4 centimeter distraction. So you will see a prominent tenting of bone as you do this by the end of the distraction. And of course, then we're going to go ahead and relocate that, and it restores.
Is there something magical about that amount, or has anyone tried to bring it up just a millimeter or 2 or 5 millimeter? Or
I don't think so. And so it's great questions. I think it's just the response. And so if you look at the original work that was done, corticotomies were done along the entire length of the tibia initially. I had some concern about that. And actually there's studies now that look at our construct, and I'm sorry I didn't comment on it. We do a 5 centimeter by 2 centimeter window. One, I think it fits very well in that metaphyseal diaphyseal junction of the proximal tibia. 2, it supports my half pins. I use 5 millimeter, typically half pins in that area. So it seems to support it well. I like it. I will argue this and as everything, which is great because as we say, a rising tide brings everybody up. There's a lot of not a lot of competition, but there's a lot of interest in this, and there's other people looking at this. And they're looking at this, and it's interesting. You started this entire discussion with scope of practice. We as a profession really focus on, and it has fallen onto us to do a lot of limb salvage in the diabetic foot world. It is a podiatric bastion. I would suggest I've been doing this for over 30 years. It's what's driven our profession to expand our scope into doing a lot of the things that we do now, because no one else wants to do it. And it still falls upon us. The problem is, again, as you said, is scope. And my concern is to accommodate scope. People are looking at doing this in an area more distal in a zone of what I consider to be dysvascular and closer to the area of pathology that we're trying to treat. I think, in my opinion, and this is my opinion, it has to be done in the proximal tibia because that remains a zone of vascularity. And it also is further away from our disease pathogen process, that we're dealing with. And so to try to accommodate to a profession that really focuses on, again, where we do in different areas of practice and our comfort to do things, to accommodate to do this, I don't think is the right thing to do. I think, in my opinion, it needs to be done in the proximal tibia. And I'll leave it at that. But so when I said this, because we've looked at all sizes of corticotomies, we've looked at all regions of the tibia to do this in, and I think, at least in my hands and what I've seen internationally and outside prior to me, is that this appears to be the right construct. Now, there's been constructs of doing 2 1 centimeter corticotomy squares, so to speak, and putting 2 half pins in that and distracting that. I don't. It is just the process that we know, putting bone under tension and its effect that creates this healing. Anyways.
Are you having the patient do their own distraction?
Yeah. So, having the patient, a lot of my patients are going to short-term rehab afterwards for lots of reasons. So we have a whole instruction sheet that goes and instructs, not dissimilar to what we've been doing with deformity correction. And if you're doing multiplanar hexapod type deformity corrections, a lot of these patients are turning their own, getting their prescriptions, turning their own dials, learning it, or instructing family members or somebody else to do it. So we have to educate. There's no question. This is a relatively simple process. So it's not a difficult thing. It's not multiplanar deformity. We're just simply distracting, and it's easy to dial this. And it will get even easier. Yeah. So we can jump to the cases. There are interesting cases, and we've got a lot more. We've now done about 25 of these, and all very challenged patients at high risk for limb loss. But this was a very gratifying, satisfying one that we can present. And there's an amazing history. He's a 46-year-old male with known diabetes, neuroischemic right heel wound. He's had 11 surgical interventions, over 4 hospital admissions. And at some point, you got to look at these patients too, and these become institutionalized patients, and these are the battles, of limb preservation, and are they, willing to persist, and could we get them going on faster with a transtibial amputation prosthesis, and these are always the questions we ask and answer. But anyways. A challenging patient, significantly infected, neuroischemic heel wound. You can see by lab results, inflammatory markers, white count.
Yeah, white blood cell count 28.6, CRP 349, ESR 44.
Yeah, and he meets SIRS criteria. I mean, I can't remember what his hemodynamics was, but this is kind of what it looked like. And nothing really aggressive on radiographs, as you can see, but it was a significant neuroischemic wound to the heel. Radiographic arterial calcifications, you can kind of see. We did our debridements. It went down to bone. We did a medial compartment. We did the standard negative pressure wound therapy on this type of patient. But the big challenge, again, is there's an ischemic component to this. And then you also have a polymicrobial disease process. Yeah. And so you've got polymicrobial, not to include yeast, not the least of which. We have a vasculopath, and so this was our initial approaches. Bone biopsy, we found that he had focal osteomyelitis. We did our debridements, offloading frames, and some approaches to try to get tissue coverage, partial calcanectomy, as we do.
Extremely complicated patient.
We all know these patients. Yeah. And then I don't know how it is for the rest of the world. I suspect it's the same, Jeff. I suspect you face the same thing. Since COVID particularly, STRS, outside institutions, step-down facilities have been extremely challenged with staffing, nursing, and I can tell you historically, I haven't seen the problems that we see now, and it's just across the board. And so a lot of things get neglected when you go to step-down facilities. And so anyways, this patient went to step-down, had some issues, he had a CHF exacerbation, so you can imagine his comorbidities, went to an outside place who simply said, well, we recommend a BKA, there's no limb salvage possible. And some patients are adamant they don't want that. And so he found his way back to us after the step down to have ongoing care, did some debridements.
Sometimes these patients start as just simply they're bed bound and they don't have Prevalon boots on. They're not heel offloaded, and it starts, and then it just spirals out of control because of their underlying comorbidities. Yeah. And all of this could in theory be prevented with some more acute, paying attention by staffing and getting the certain correct people into offloading boots, and just some very simple
I see it all the time. Measures. See it all the time, and it's sad, and it's true, and so much can be preventable. Yeah. But this is kind of where we are. Did a advanced calcanectomy, try to get things granulating, X-Fix offloader that we do. Wound vac again, got some good granulation. Brought him back in, actually, and because I do some orthoplastics, we did try to do a distally based lateral plantar artery pedicle flap. It was based off the perforator off the lateral plantar artery, and then rotated it in place to get some coverage. And we can go on. Like a lot of these, so unfortunately the distal portion of flap necrosed for us. So we kept on going on, and so we removed the X-Fix, debrided, did some skin substitutes, extracellular matrix type of skin sub that we did here. Try to get things granulated, returning, got some good developing granulation, but the biggest barrier for this guy was this ongoing microvascular disease. And so we were battling it. He had undergone a revasc. And so this is when we elected, hey, this guy's going down the road of the BK, as they were suggesting, get outside institution. Let's go ahead and do a corticotomy on this fellow and do, again, an extracellular matrix wound coverage. So that's what we did for him. Proceeded accordingly. Developed, actually, interestingly, gangrenous second and third toes along this process. And I think he had a completely occluded posterior tibial artery, which was a challenge, partly probably why my lateral plantar flap didn't work, although I could Doppler perforator there. Developed gangrenous digits, again, polymicrobial, lots of different courses of antibiotics. Ultimately did ray resections 2 and 3, kind of took the Chris Bibbo technique of putting a monorail to close down the ray resection. Kind of kept moving forward, but we started seeing advanced granulation and healing as things went on. Closure, used our wound vac to the point where we could put a split thickness skin graft over that area. Got him moving forward, and kind of left him with this. When all is said and done. and so a lot of effort. He's functioning with this very well with diabetic footwear, and is bipedal. And so this was, for us, labor intensive, but nice to see a nice outcome of the limb salvage that really in a lot of other places, and one could argue, could have had a below knee amputation and moving on with a prosthetic. But he was vested too.
Yeah, this is amazing. So, if anyone's not looking, we start with a pretty significant heel wound down to the bone, partial calcanectomy, multiple ray resection. I mean, this patient is destined for failure. But with the tibial corticotomy to establish angiogenesis and get better blood flow down there on a otherwise non-reconstructible vascular patient, we have full healing essentially of this wound. He's down 2 toes, but he's got his leg and he's functional. So that's amazing.
He's a happy patient.
Go ahead.
No, I'm sorry, Jeff. No, he's a happy patient. I mean, ultimately, the proof is in the pudding because we know the challenges with these patients, persistence of remission, sustainability. But that's the case no matter what we're doing. And so the biggest part, and I will say, as you know it too, is having patient buy-in. And willing to go through the process. And that's the biggest thing, is selecting the patient, understanding their ability to buy into this and willingness to do this.
I think you can tell a significant difference when we've all looked at enough feet, foot and ankles in our days. You could just look at the skin and see that it looks healthy and more vascular and more vibrant than it did before. But are you typically ordering pre and post tibial corticotomy angios to be able to compare that and verify that it did in fact work, or are you just looking at the foot and saying, of course it worked, look at this, it's healed?
I've done both, and again, one is you got to look at value, but I work very closely with our vascular surgeons, so this is not done independently. So this is done very closely with vascular. A good majority of these patients, and I would say 75%, have had some type of endovascular or open procedure to get some conduit down. Now, if you look at the Chinese orthopedic community and their consensus statement with regards to doing this, they demand patency of 1 blood vessel down to the foot to do this. And that, I follow that guideline. I will say there is literature and performance of this when there's no patency of any blood vessels down to the foot with good outcomes as well.
Wow, that's amazing.
But I follow the consensus that I want 1 patent vessel, which means I need my vascular colleagues, and in the majority of these cases, they do catheter angiograms. We tried, many of these patients have renal disease. We got to be careful a little bit about CTAs and all that kind of stuff. So, but I have, in a good number of these, we do have pre and post TTT catheter angiograms showing the robust collateralization and revascularization and follow-up. And that's usually at about 8 to 10 weeks when we see that. And what's amazing is, and I was asked this, you see actually a beginning of vascular response in about 2 weeks And once you start, after the latency and you start doing the distraction and you complete the distraction, you begin to see this arterial perfusion that you don't see, this bleeding that comes from a wound that never had bleeding before, which
Yeah.
is quite impressive.
That's pretty instantaneous. That's pretty
Yeah,
quick.
yeah.
We have a 60-year-old male that presented to the emergency department with left heel ulcer, concern for diabetic foot infection, redness, swelling, drainage, and fever for 3 days.
Yeah, so another notable neuroischemic wound to the heel, no real ability. I mean, you've got infection, you've got poor perfusion, inability for healing. You can see on x-ray the extensive radiographic arterial calcifications that these patients have.
White blood cell count almost
White
20.
through the roof again.
Inflammatory markers sky high. Hemoglobin A1C elevated.
And so we do this. In this case, was a CTA done, and you can see pain vessels. Most of these have infrapopliteal disease. We recognize that, and then ASO distal attenuation. Started on our broad spectrums. Wasn't really changing with local wound care. What do we do now? And we did an incision and drainage, again, in the neuroischemic wound with thrombosed tissue, nothing vascular in that area, deep abscess pocket. We started to see improvement in white count. And we said, well, with this neuroischemic wound, let's go ahead and do our tibial corticotomy to see if we could advance this process. And we use thermography. Thermography is great. I use it a lot for my flaps and things. I don't have in my system any type of continuous flap monitoring system, so thermography works great. Yeah, a very simple device that you can get off Amazon just to see our tissue perfusion, advancing follow-ups, white counts coming down, healing, granulation. I don't know if we have a final outcome, but fully healed on that. This is kind of our this is prior when I put this first presentation together where we stood with things.
Yeah.
So looking at things.
Where do we stand with this? What's our success rate? What are our outcomes? Where are we at with everything?
So let's go back to that. Let's go back. Thus far, I will say I have had one major amputation, and that's because of the patient that was selection. I was going down that road, but the patient didn't want to lose their limb. We tried to actually did a huge reverseral flap on him, just a very sick, a lot of comorbidities. Knew there was limited chance, but I will say that it's a major amputation that we had. Now, I will also say, what is the worst scenario that can occur for these patients is that they're already going down the road of having a major amputation of one. The biggest concern I have with this, and even where I'm doing it, is that I can't preserve a below-knee amputation, and they end up having an above-knee amputation, which is an entirely different animal. Right? So that is a concern. To date, we haven't had, the one hasn't happened, but that's always a concern. Yeah. We've had now a complete tibial fracture, which we're dealing with this weekend, so that is a known complication.
And that was the monorail?
No, that was through a ring fixator. The ring fixator was off and done, and it seemed like insufficiency and still hadn't completely healed a tibial osteotomy.
I see. It was completed, and the ring fixator was off, and then they fell.
And they fell and fractured through that.
I see.
Pin tract infections, as we all expect, one grade 5 that we had to treat. We had 3 developed secondary gangrene of digits, one that we showed on that case. We locally managed with debridement, isolated amputation, or TMA, but we never gone proximal to TMA. And so far, we've had no infections at the corticotomy site. I can't say that's not necessarily the case with this insufficiency fracture I'm dealing with, because he had draining sinus to one of the corticotomy, to one of the half pin sites. So that insufficiency fracture likely was infectious, and so I can't say that not being the case. So I'm going to put that into the category if we probably have had an infection of corticotomy site at this point.
So overall, highly successessal, considering the patient population and what the alternative would be.
Correct.
Is that fair to say?
Very fair to say. Yeah. All these patients that we are no option, are going down the road that they're going to have a major limb amputation. and they're given this opportunity, we can attempt this, providing it's reasonable. And again, I had that one patient where I said maybe just because I could, maybe I shouldn't have. But to date, we've mimicked what the Chinese orthopedic literature in general, looking at them with 90% limb salvage rate or higher, and we've had the same thing.
So this is essentially reserved for, well, let's word it this way. These patients are highly complicated. We know that there are lots of things that we can typically try: revascularization with vascular intervention, localized wound care, antibiotics, skin grafts, other products. What role in the future do you think that if there is some vascular insufficiency, that we skip those first 8 surgeries and we just jump to this quicker? Or what's your indication? Are you waiting for
Yeah,
something
that's a
else to
great
fail?
question. Yeah, and I'm pushing that envelope. I will say this is an interesting thing that you bring up, and I will give a shout out to my friend and colleague Noman Siddiqui in Baltimore at Reuben, where he's looking at his septic ankles and his septic Charcot ankles and doing talectomies, tibial-calcaneal fusions, and then doing distal distraction osteogenesis for restoration of length. And his initial study, I think he had a cohort of 15 patients with over 90% fusion rate. When I last spoke to him less than a month ago, he's now got that up to about 50. And he still has a over 90% fusion, tibial-calcaneal fusion rate in combination with the distraction osteogenesis of the tibia for lengthening. And I say that to you because it's the same principle.
Yeah.
These would be challenging fusions in that cohort of patients, and I think the humoral response of doing distraction osteogenesis for lengthening has contributed to the augmentation and healing of those fusions. So I think there is a place for where we have challenged non-unions in some of these patients, or even increasing the scope or the looking at our diabetic foot wounds, where we can follow these down to maybe a less severe Wi-Fi or Wagner wound presentation, where there may be some benefit, as long as we know that the risk associated with doing a proximal tibial corticotomy is not outweighing the benefit. And I've kind of been very cautious to date for that reason, because it's still not a benign procedure, and I want to make sure that I'm not doing a bunch of these and all of a sudden I'm getting a bunch of insufficiency proximal tibial fractures that my ortho colleagues have to put anti-grade nails down and stabilize in that. So I'm still cautious, but as I feel more comfortable in seeing the outcomes, I do believe there will be a place where we can advance this more. Now then you can start arguing, well, what about hyperbaric and all these other things that have shown some potential benefit, and is that a safer thing to do than doing a corticotomy and putting a patient into an X-fix? We have to look at all of that,
It seems like there isn't anything out there that elicits quite the cellular response as this does, and the proof is in the pudding when you see that. We've tried a bunch of other things, whether it be hyperbarics or stem cells, pluripotent, whatever, inject this, put this graft on, try that, but it doesn't seem, maybe the answer all along was the human body, even as decrepit as some of them may be, unfortunately, that has the power to heal if we do the right thing. So it's kind of interesting to think about from that standpoint. We've been doing all these external things for so long, but maybe the body's own capacity to heal was the answer all along.
I think you're absolutely right, and I think we're learning that more and more, particularly in regenerative medicine. I will say, as a side note, we actually did one of these in bilateral guillotine TMAs, both with neuroischemic presentation, and we only applied it to one leg, and we got healing to both.
Wow.
And so that tells me, and then I said, well, but interesting, there's already literature supporting that that's already been produced and everything.
Yeah.
So, the body's ability to heal, and if our ability to harness it correctly, I think that's going to be the answer in so much of what we treat, for sure.
That's amazing. Thank you so much for joining me today and talking through this emerging technology, at least here, in China, and going back to Elizarov, some of the foundational principles have been laid, but thank you for your time and explaining that to us and advancing this really interesting technique.
Thanks for having me, Jeff. I truly appreciate it. And continue your great work in doing this and putting this out to the community.
Appreciate it. Thanks for joining me today on this episode of Paw Patrol with your host, Dr. Jeff Dykes. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.